Good afternoon, everyone. My name is Nada Santrac. I am a surgeon from Belgrade, Serbia. My co-moderator today will be esteemed Professor Gilles Dolivet, a surgeon from Nancy, France. Hi, Gilles.
Hello, Nada.
We are both members of ESSO Education Training Committee for Endocrine, Melanoma, and Sarcoma, and we would like to welcome you all to today's webinar on evaluation and management of thyroid nodules. We have designed for you a series of educational webinars on thyroid surgery from basic to expert level. We aim to provide participants with a full range of updated information on diagnostics and treatment of thyroid cancers, as well as surgical complications and their management. This first webinar of the series will focus on thyroid nodules diagnostics and surgical and non-surgical treatment modalities. We wanted to start with some of the best in the field, and we are very happy to host today's two speakers whose names and reputations ensure a lot of quality talk. Our first speaker today is Dr. Andrea Casaril, Chief of Endocrine Surgery at Pederzoli Hospital in Verona, Italy. He is very engaged in educational activities, and he is an expert in endocrine surgery, a mentor for many young residents and surgeons. He is a board member of the Italian Society for Endocrine Surgery, and we welcome you to today's webinar, Andrea.
Thank you.
Our second speaker today will be Professor Ozer Makay from Izmir, Turkey. He is a fellow of a European Board of Surgery, member of many scientific boards, organizer of numerous educational events, visiting professor in Thessaloniki, Greece, and Coimbra, Portugal. And I must proudly add that soon he will become a visiting professor at Belgrade University Medical School as well. We are happy and honored to have both of you today as speakers, and we expect a lot of good discussion. Now let's hear our first talk for tonight on non-surgical treatments for thyroid nodules. Andrea, we can't wait to hear when and how we can go with non-surgical approach in treatment of thyroid nodules.
Okay, can I start with the condivision of the my desktop? Okay. First of all, I want to thank the organizer for the kind invitation. It's an honor for me and to have this opportunity. I will speak about the non-surgical treatments for thyroid nodules today. So we know that benign nodules are dangerous like a fluid, no more, in the thyroid, in the neck, because they only take volumes, so they only can give compressive symptoms, aesthetic impairment, and can have a growth trend in the time. So they have an increasing chance to undergo to surgery depending by their size. And our aim today is to decrease the volume, to improve the symptoms, and to improve the aesthetic impairment. So we know that when we look at the face, our attention is focused on the triangle made by the eyes, nose, and mouth. But if a scar is on the neck, we always look at the neck, at the scar immediately, as proved in the eye tracking studies performed for the transoral approach, the transoral surgical approach. Of course, we know that for more than 1 century, the thyroidectomy stays not stays as well as Cocker did it, but in the last 2 decades, some more developments were made for having a minimal invasive approach by the real minimal invasive assisted thyroidectomy, the transaxillary approach, most endoscopic or robotic, some others approach with less popularity, and in the last few years, the transoral approach. Our aim now is to avoid the surgery, if is possible, to spare the thyroid tissue, to preserve the thyroid function, avoiding a lifelong therapy with the L-thyroxine, preserving the aesthetic if we can. So we have to do something that is minimally invasive, with the minimal impact on the quality of the life of the patient, preserving the safety and preserving the same results. Percutaneous thermal ablation seems to be the perfect method to have this kind of a purpose. We can do it with the microwaves, with radio frequency, with laser, and in the last few years, the HIFU is losing popularity. The preparative study for this kind of patient takes in account that all of them have to be Bethesda Thai-2 at fine needle aspiration. The calcitonin must to be negative, and we have to be sure that we have no suspicion at the ultrasonography examination of any malignancy. The features of the nodules are studied by the ultrasonography, and the nodules are divided in solid, microcystic or spongiform, partially or totally cystics. A symptom score is recorded by a visual analog scale, and the cosmetic score is recorded in 4 points if the nodule is not palpable, if it is visible but palpable, if it is visible only during swallowing or neck extension, or if the nodule is always visible. So our inclusion criteria are nodules between 25 and 50 millimeters, even if it's better to talk about volumes and not on linear diameter. All nodules have to be benign. I told again, they have to be symptomatic or give an impairment of aesthetic of the neck. They have to demonstrate a growth trend during the time, and of course, surgery contraindication or surgery refusal that is quite uncommon must be an inclusion criteria. The growth trend is very important, in my opinion, because we are talking about volumes. This is the formula to calculate the volume of each nodule, and some recommendation and some points to be stressed. A volume, a nodule who has the 12 per 10 per 11 millimeters has a volume of 0.6 milliliters. And for a slight increase of any linear diameter, we have a huge increase of the volume. Every time the volume is more than double. So we have to consider then if we have an increase more than double, less than double in linear diameter, the volume is in reality more than 6 times in comparison of the beginning. So if we consider that the growth trend is often constant or increasing in the time, and the ablation success is related to the initial volume, and that low volume requires low power, less time, so the success is more frequent, we may consider the growth trend as an indication for thermal ablation, avoiding a future surgery. Some example, at the CT scan, female, 24 milliliters of volume, a growth trend of 43% per year for more than 3 years, consecutive 3 years, symptomatic score of 8 and cosmetic score of 3. And US evaluation, young female, 19 milliliters of volume, growth trend of 40% per year for more than 3 years, and symptomatic score of 8 again, and cosmetic score of 3. So we can think that for those kind of patients, the thermal ablation could be an indication as first-line treatment and the first choice for the patient and of the patient, because the patient requests have to be considered. Exclusion criteria or contraindications are the hyperthyroidism, but not all, because we can treat with ablation also small autonomous functioning nodules. Every nodule that is Thy3 or superior at the fine needle aspiration, if we have the suspicious at the US evaluation of malignancy, if we had a previous contralateral lobectomy, or otherwise we have to perform a laryngoscopy to the nodule, the remnant lobe, head and neck irradiation or surgery in the next years, in the past years, or severe bleeding or coagulopathy, and the mediasthenic involvement of the nodule. Very important is to stress this point, the suspicious of malignancy at ultrasonography evaluation, because even if you have two fine needle aspiration negative, Thy2 of Bethesda, the suspicious at ultrasonography is a contraindication for the thermal ablation. In Italy, we had an increasing in detection and surgery for cancer. So more or less 25,000 thyroidectomies should be needed for benign. Of course, we have goiter, and not all are uninodular, but the number is very huge. And so for many years, the surgery was the only weapon we had against the thyroid diseases, but we can consider that we can split our energy in against the large Thy2 nodules with a thermal ablation. And this is not the topic, but selected cases of micropapillary cancers and selected cases of autonomous functioning thyroid nodules could be treated by thermal ablation. Surgery could be used against the malignancy, of course, goiter, and all the other autonomous functioning nodules. So if we split the waiting list, we can have a short waiting list for ablation for benign diseases, and we can make shorter the surgical waiting list for cancer and other diseases. Not only this, but we can save time, we can save occupancy in the hospital, and we can save money. We can save money because surgery needs much more time than ablation in the operating room. It's not only the operating time, but all the occupation of the operating room. And nowadays, it requires an energy-based device, and in most cases, the neuromonitoring. Ablation requires only half an hour occupation time in the operating room, and only the antenna or the needle. In head, we have to consider that sometimes, or most times, we have to take into account the cost for a lifelong replacement therapy after the surgery. And in few cases, but it happens, the money compensation for the damage to the inferior laryngeal nerve. The efficacy of the ablation is we can measure the efficacy by the volume reduction rate. This is the formula, the initial volume minus the final volume divided for the initial volume reported to 100. And the peak is at the third month after the ablation, and then slowly it continues in the time till 12 months, till 1 year, sorry. The volume reduction rate must reach the 90% of the volume in 1 year, slightly and slowly during the time. And we have to consider not only the volume reduction rate, but also the increasing of the symptomatic score and the cosmetic score. This is the 3 points we have to consider to assess the success of the ablation. This is a crucial point. We are talking about volumes. This is a big nodule, but it happens quite often to see some of them. The linear diameter are 45 per 40 per 43, for example. The volume is 40 milliliters. If we decrease the volume by 70%, the volume will be 12 milliliters, and the linear diameter will be 31 per 26 per 28. Our best results, we said, is to decrease the volume by 90%. So final volume will be 4 milliliters, and this will be the final diameter, more or less 21 per 18 per 20. So it's very important that we have a very good communication to the patient that the linear diameter does not decrease by the 90%, but is the volume to decrease the 90%. If we do not have this kind of communication with a perfect informed consent to the patient will feel this result like a failure. So they have to know before the procedure that the diameter will be a little bit more than a half than the beginning. Comparing the surgical procedure, the surgical resection with the ablation, of course, we have some advantages about the ablation. The complications are less in the ablation group. The time is less, and the invasiveness is less in the ablation group, of course. But one very important advantage is that after ablation, usually we do not have any change in thyroid function, so we don't need any levothyroxine therapy after the ablation. This is very important for the patient. The symptom score and the cosmetic score shows no differences in the 2 groups, surgical and ablation. But of course, the static results are much more better in the ablation group because we have no scar. How about the satisfaction? The global satisfaction, of course, is in favor of the thyroid ablation group when compared to the surgery. And this is the same for the quality of life. And if the patient have to recommend a treatment, is much more like recommended the ablation rather than the surgery. But is also true that the surgical group has a better result in terms of decreasing the symptomatology, and this is due of the fact that we put away the nodule, of course, with the surgery, and we only decrease the nodule with the ablation. So if we compare the outcomes between thermal ablation, conventional thyroidectomy, and thermal ablation with endoscopic thyroidectomies, we have the same outcomes, but some advantages as the treatment time, days of hospital, medical costs, and post-operative thyroidism in favor of the thermal ablation. And when we compare the satisfaction is much more better in thermal ablation in comparison on conventional thyroidectomy, but is more or less the same. The satisfaction is more or less the same between the thermal ablation and the endoscopic thyroidectomy. And for endoscopic, we are talking about the transaxillary, the areolar, and the transoral. For the psychological impact, it seems that the is much more accepted thermal ablation rather than a surgical approach, but it's quite natural. And what to choose? Radio-free. I have no interest, and I never used laser, so I cannot tell anything about laser. But what to choose between radio frequency or microwaves? It depends. The results are more or less the same between radio frequency and microwave groups, both for primary endpoints, so the volume reduction rate at 1, 3, 6, and 12 months, and secondary endpoints like the symptomatic and cosmetic improvement at 6 and 12 months. This fact is demonstrated in a lot of literature, and even if in some group it seems that radio frequency is a little bit better in terms of volume reduction rate, the results for symptoms and cosmetic score are the same for both kind of energy. So you can use what you are confident with. Complications. Complications are related to the surrounding structure. Of course, the first is the skin. We have to remember that we do not provide any burn on the skin, and we can have pain during or after procedure, and we have to inform the patient that they can have pain on the jaw, on the back of the neck. Is normal. If they know before the procedure starting, they will be not afraid during the procedure. We can have, of course, hoarseness with transient or permanent change of the voice, subcutaneous or subplatysmal hematomas, and is very unfrequent, uncommon to have an abscess after the hematoma, and visceral or vascular injuries are really, really uncommon. You have to do a very big mistake to have a visceral or vascular injury. So safety comes first, we know, and we are talking about benign nodules. And so you have to remember then when you put inside the nodules an antenna or a needle, you don't have to destroy everything in the nodule. You have only to decrease the volume to improve the symptoms, to improve the static. So ablate the most part of the nodule, but take care of a safety zone, and the zone, the side you have to take care about is the tracheoesophageal groove, and the distance must be more than 4 millimeters. This study was very interesting because they analyzed the distance between the anterior capsula, the medial capsula, and the tracheoesophageal groove, and the isolating fluid they use, and they obtained a nomogram to have a risk of hoarseness, sorry by the light, after the procedure. The technique, the most used technique is the moving shot technique. The approach is transseismic. It provides multiple shots in the nodule. You must have in your mind the three-dimensional disposition of the nodule, and this is used mostly for the radio frequency energy. We developed our own technique. We called it fluid motion technique, and we had the same result like in literature for about the volume reduction rate, the cosmetic and symptomatic score improvement. We use a frontal position, and so we are not on the back of the patient without any sedation for the patient, only local anesthesia at the entry point. The access to the nodule is direct, so it's not transseismic like in the moving shot. We use an uncooled 17 or 18 gauge antenna, and we give in the same time a thermal and mechanical damage to the nodule giving a predictable and controlled release of low wattage of energy. The wattage ranges between 10 and 20, no more than 20 watts in the nodule. Only a few videos. The local anesthesia is performed without any hydrodissection around the thyroid capsule. We want that the patient who can talk during the procedure can tell us if she or he has pain. The needle is inserted right into the nodule, and when is in the nodule, the energy start to be released, and when the consistency of the nodule starts changing, the operator starts moving fluidly inside the nodule, releasing the energy and because the wattage is very, very low, the real-time monitoring of what we have ablated and what is not yet ablated is possible. So this kind of fluid movement is very useful to see what we have ablated in real time. So in our endocrine unit, we moved from this situation about 70% of open procedure, 23% of minimal invasive, and 7% of transoral into this kind of procedure. We gained the 20% of patients treated by ablation, 52 by open, a little bit more, less than 5% for transoral, and unchanged the percentage of minimal invasive, because the indication, of course, are different. But this is very important, what I'm just saying. Make really attention. This is a crucial point for me. I always want to stress this point. Surgeon, endocrinologist, and interventional radiologist must work together, like in the thyroid unit. This is very important. I want to underline several times, because I saw in the last few years a lot of physicians or surgeons alone, endocrinologists alone, or interventional radiology alone, starting to use ablation, which is very simple to use by themselves. I think it's a very big mistake. So we have to send a very clear message. The team works together. So thermal ablation reach the goals we have, is safe or safer, and is cheap or cheaper in comparison to surgery. Needs no therapy after the ablation, is a preserved aesthetic. So why surgery? And once again, one operator is needed, only one nurse is needed, 6-8 patients in the morning. So why surgery? Because we have to take into account a lot of aspects, the indications, the money. Not all hospital wants to buy antennas or a generator, the training, our experiences, the problem of the relapses of the nodules, the failure of the procedure. We have actually 8% of failure and relapses. The cytology, we have to be quite sure about the cytology before treating a nodule by ablation. The US suspicious, we have to perform the ultrasonography by ourselves. I think the volume of the nodule, some predictor factors. We do not have any predictor factor at the moment. We sure the team opinion and the team availability, of course, our medical experience, medical preference, and most important, perhaps, what the patient is requesting for. So we have some weapon for thyroidectomy, the open procedure, minimally invasive, the robotic, the transoral or other endoscopic, the ablation, as is our job to choose what is better to use for the patient. So about the indications, our resources, the patient's request, our experience, of course, the team works. Thank you for your attention. I turn up the light.
Thank you very much for this beautiful presentation, Andrea.
Yes, it was amazing, and I think it's very useful for us surgeons to hear about this, because I'm sure that we have little knowledge on indications and possible complications of non-surgical treatment modalities. We have received a lot of questions, Gilles, right?
Yes, we have seen them. So the questions are practical about the number of nodules you can treat in the same time, mainly. And personally have a question about the learning curve and who should practice the thermal ablation? Surgeon, interventional radiologist?
Okay, for the number of the nodule, at the moment, we recommend to start with uninodular disease. So when you have only one nodule in the thyroid. After that, now we are performing ablation for 13 years with 10 years with radiofrequency, the last 3 years with microwave. So our operator, and I will say which is the operator, has a big experience. Now we are trying to treat some special cases for multinodular goiter, but our experience for the moment is on the uninodular goiter. I am a surgeon. I don't use any needle. I don't use any antenna. My interventional radiologist do it, and maybe they have the most experience to do it. So in our hospital, we are divided. I give the main indication. He performed the ablation. Of course, at the beginning, we had a consensus for which patient have to be ablated, which patient have to go through surgery, and so on. So now we know what to do. But the operator is the radiologist in our hospital.
So you probably discuss it as a MDT before the treatment?
Yeah, yes, not for
special
all.
MDT or?
Not for all. At the beginning, we had our indication, and we only discuss some special cases. For example, all the patient, all that kind of patient that refuse surgery, even if it's indicated. For example, if we have very huge nodule, 100, 110 millimeters is very huge. I think ablation is contraindicated, even if you can repeat more than one session. The best option is surgery, but someone don't want to undergo to surgery. In that cases, we discuss the special case.
And I have the experience of, I have seen some complication with tracheoesophageal necrosis and death of patients. Have you any comment about this type of complication, and how do you manage it if you have some?
No, luckily we don't have any this kind of complication, but I think that is because in the last few years, what the company can provide are tools that are in much more better as the technology. I told that we use a very low wattage, 10 to 20, no more. So the energy is very soft. Is very rare and uncommon to give a heat damage outside the thyroid. Not only. We do not perform any anesthesia on the capsule, so the patient can feel the pain. If she or he tells that the pain is increasing, we know that we are too close to the capsule, so we turn off the generator, or we withdraw the needle to avoid any damage. This is a very good trick. And but the main point is that the technology is improving year by year, and they are giving us a needle that use very low wattage with the same efficacy. So it's much more safe than some years ago.
Let me ask you
you.
something from a surgeon's perspective. Have you done surgeries after thermal ablation or
Yes.
whatever non-surgical modality? And what is the situation in the operating field? Does anything change?
This is a very good question. We had some failure or some relapses, and the patient underwent to surgery, and for the same reason, because we do not hit nothing beyond the capsula, we did not find anything different from a first intervention. So we don't have any difficulty, any adjunct, any problem, and we don't have any adhesion, and the surgery was perfect, like it was at the beginning.
So it is very important to do it very
Yes, it's very
carefully
important.
with least possible damage of the surrounding tissue. There was one question just arrived, which can just follow my question. What about some challenging situations when you have posterior nodules that are near esophagus or carotid sheath? Do you dare to treat them with ablation or not?
As I told, it depends. Sometimes you can suggest for the position of the nodule that the surgery is the better option. If the patient wants the ablation, you can discuss with him. We don't have any problem with the carotid sheath. We pay a lot of attention to the esophagus, of course, but we always have at least 5 millimeters of margin between the tip of the antenna and the capsula of the thyroid. And as I told, the energy with these new devices is released in very gentle and very soft way. So it doesn't burn anything beyond the 5 millimeters. So if you have a good control of the tip of the antenna, you don't have a high risk. And this is the why we do not treat the nodules with the mediastinic involvement, because we do not follow in a correct way the tip of the needle because of the clavicula. So we do not want to treat anything we don't see in the right way.
So thank you very much. Time is passing. And Nada, do you think we have to go to the other presentation?
Yes, absolutely. I think we can move forward for the second talk of today's webinar. First, I would like to thank Ozer for joining us today. He will talk on recommendations for diagnostics and surgical treatment of thyroid nodules. It is a pleasure to have you, Ozer. The floor is yours.
Thank you so much. I'm sorry for suffering of the time difference. I was told different, actually. So, but I hope I didn't miss a lot. Do you have my presentation now?
Yes, we see it.
Okay, great. It was very great to listen once again to Andrea, and I have seen that he received a lot of questions, not being provocative, but there is an enormous interest. And I'm the one who also show interest with visiting him and starting the program here in our setting as well with my interventional radiologist. So I really do care about the philosophy he is presenting. This talk will be a 15 to 20 minutes talk about the recommendations of thyroid nodules, but it's really, simple, not technical, but I still see that we suffer a lot in the management of thyroid nodules. So possibly I'm going to underline some things, what is really not going well in real life. I thank Nada very much for having me on this platform. And I'm very honored, and I'm very happy actually to do a lot of things together. And in the future, I'm sure that we will do more. I have nothing to disclose. This is a very, a beginning slide. Here I want to present you that actually to underline that even the prevalence of nodule is high, with reaching 70% with the ultrasounds that we carry out. Most of them are benign, and that doesn't mean that every nodule receive a surgery. So this is what's happening also on the platform in Turkey as well. So if you have a nodule, taking into consideration the increasing incidence of thyroid cancer, since it has been in the second row after breast cancer in Turkey, we see that some surgeons advise thyroidectomy for a benign nodule. So there is something where we have to stay. When it's about nodules, we do care about the number, of course, about the shape, the internal structure, the function, and even the histological type, of course. So when it's about this nodule, about the number, it's we have to ask ourselves whether it's solitary or multiple. Does it make a difference? Yes. In decision making, it has a sense, as you have heard also from Andrea. So we may behave different in a multinodular goiter than in a nodular goiter. The shape definitely has an importance. That's where we have to invest ourselves, because taller than wide means different than a round, regular shaped thyroid nodule. The internal structure is important, whether it's solid or cystic. And if we have a suppressed TSH, we will go for the function. And we really wonder whether we have a productive hyperactive nodule, or is it about this hyperactivity that suppresses the TSH, not regarding the nodule, but regarding the parenchyma of the thyroid. And of course, we do care about having a neoplastic or a non-neoplastic nodule. How do we detect these nodules? We can detect them clinically. Patients generally feel that swelling in the neck, which may cause thyroid dysfunction or compressive symptoms, but they can totally be detected incidentally. This is what happens also in our routine outpatient clinic. What we've seen, they're detecting in general during the imaging of non-thyroid reasons, but here I will underline again the importance of physical examination, because recently we do have forgotten physical examinations, but really you get very important clues with the physical examination regarding the nodule, regarding the lymph node as well, and of course the thyroid tissue itself. How do we detect these thyroid nodules in general? It's general with the neck ultrasound, which has been carried out for other reasons, or it's a CT or an MRI, or a PET-CT. So we are aging and we are dying later. And this means we have a geriatric population which is growing. And these patients generally may suffer from a cancer, and so they receive the PET-CTs. So this is also a very routine what we see, incidentally discovered thyroid nodules. But we have to concentrate on the thyroid, whether it's a PET-CT positive nodule, or is it because of the thyroid disease what's there. So we shouldn't forget that, for example, Hashimoto thyroiditis can also be PET-CT positive. So that means we have to evaluate actually all the thyroid nodules, even so common, especially we are investing ourselves in the risk of cancer. So that's why ATA recommended all incidental thyroid nodules which are detected by MRI or CT should be evaluated with the ultrasound. And if there is an activity, a focal activity, not a parenchymal activity, detected during PET-CT, ultrasound should be performed. And if a nodule is detected, FNE is recommended. So what does it mean actually? A PET-CT positive focal activity uptake means more than 30% thyroid cancer. Another very basic thing is that we have to go for not all the thyroid profile that you can get from your laboratory. Normally, TSH is more than enough, which is a primary test in evaluating the thyroid function. You may go for the free T4. This is especially important for those patients who are actually thyrotoxic. And whether it's a Hashimoto thyroiditis, yes or no, of course, you can ask for the antibodies as well, as long as your laboratory are serving them. But it's, of course, not a per se test what you go for. But this is very important if you go for an FNAB, since the cytologist wants to know whether this patient has antibodies positive, whether he or she has Hashimoto thyroiditis, because this has an impact on decision-making even during the cytology. Ultrasound is excellent, and it's, we nearly have it everywhere, even in our pockets with our, with a very simple probe. But experience definitely matters. This is what we have learned throughout the years. We have to have a detailed examination, not only of the thyroid, not only of every single nodule, but also of the cervical lymph node. So if you have if you have an ultrasound reporting only nodules regarding thyroid, this will not be sufficient. So don't be happy with that. Always ask for a cervical lymph node ultrasound as well. Ultrasound is non-invasive and it's repeatable. And as long as you have a device which is good quality, it's quite more than enough. But again, I want to underline this, the presence of an experienced radiologist. So as surgeons, we should know how to look, where to look, and for decision making. But on the other hand, the experienced radiologist definitely matters. What do we look for actually? Actually, what do we have to look for in our reports? Sometimes I receive a report of only one sentence. It's describing a multinodular goiter patient, but it's only one sentence. This is actually very successful how they do it, because I would, as a surgeon, as a clinician who is investing himself in thyroidology, I really wanted the thyroid features, the nodule features, and the lymph node features. And if it's about the thyroid features, I want to have information about the size of the lobes, about echogenicity, about this tissue structure, whether it's homogeneous or heterogeneous, about the vascularity, the trachea, whether it has any impact on the trachea. And some of us, they do invest themselves in the thickness of the isthmus as well. And whether the nodule, I really look for how many there are, the sizes, the location, the echogenicity, the composition, whether there are echogenic foci in it, the margins, the vascularities, and whether there are some suspicious features as well. And this is also true for the lymph nodes. So beyond the size, the shape, the presence of calcifications, cystic change, the localization, the vascular characteristics, echogenicity also has an utmost importance. That's why, since the ultrasound is the stethoscope of nodule evaluation, you see a lot of investment in risk classifications. These are risks, not describing, whether the patient has a potential to die, to suffer, but we really do invest ourselves in the risk of malignancy, where we should be very clear with high sensitivity and specificity. That's why the ATA, the ACR, and the EU and a group in the European Union, they describe risk classifications, what we use today in our routine ultrasound reporting, which is the ACR thyroids, for example, for most of the Americans, the EU thyroids for the Europeans. So this is an example from the ATA ultrasound risk classification. So we really have to look for all these description in every single report. If you have a microcalcification in an hypoechogenic nodule which has, for example, irregular margins, this is really a high suspicious nodule. And this means that this patient has a 70 to 90% risk of malignancy. So that's why I'm underlining the importance of the presence of a good ultrasound carried out in experienced hands. But on the other hand, if you have just a pure cystic nodule, for example, the risk of malignancy is not more than 1%. as you see here. But even if we see a cystic nodule, we should concentrate whether it has any solid component. So to tell that it's a nodule with benign features, it should not contain any solid component. So if it has a solid component, it should warn us about possibly suspicious nodule as well. So how do we manage actually with this ultrasound pattern? I already, as you have seen here, every single data or category has an special has its own risk of malignancy. But how to react actually? For example, you have a high suspicious nodule, which has actually a risk of between 70–90%. FNAB, according to the ATA, is recommended in nodules which are bigger than 1 centimeter. If you look at the Turkish guidelines, for example, in regard of what the size is, even it's a sub-centimeter, the Turkish guidelines, they do advise FNAB. So there are a lot of guidelines. No one is a Bible or any holy book, but it's just a suggestion. So if you need guidance, please refer to one of these guides, which will be helpful in your decision-making as well. But if you have, for example, a benign nodule without any suspicion, there is no need for biopsy according to ATA. If we look at the ACR thyroid classification, it's again a spectrum from benign to high suspicion. So I think this is very important to know what's thyroids 1, 2, 3, 4, 5, which has different risk of malignancies. The recommendations, again, change from size to size. And the report that you receive, it's generally described in the thyroid's classification state. So that's why it's important, for example, how to manage that patient, which is described as having a thyroid 4 thyroid nodule, which means this patient has a risk of around 5 to 20% according to the ACR. And if this nodule is bigger than 1.5 centimeter, then FNAB can be recommended. And this counts also for the EU thyroids, which we use more in the European platform. Just give you an example. You have a nodule, which is EU thyroids 5 described. You see it on the ultrasound. You have already done your physical examination and all your questionings and gone through the risk factors, whether there is a family history or a history of radiation. That means if you have, for example, a nodule, again, the EU thyroids advises an FNAB in a nodule which is bigger than 1 centimeter, as presented here. What about the multinodular goiter? If we think that the patient has more than 1 nodules and they all are, which has a low thyroids around 2, FNAB may there may be an indication for FNAB, but this is based on the nodule characteristics and of course the size. So just concentrate yourself again on the thyroid classification. So if you have a multinodular pattern, if you have a thyroid 3, for example, and if this nodule is 2.5 centimeter, you will go for the FNAB instead of following up this patient. And if there are indications for FNAB, and if it's more than 3 or more nodules, then you pick out. It's not possible. It's possible, but it's really very annoying. The patient will not tolerate this. You have increased additional risks like, bleeding. If it's an risky patient, you will the system will suffer from increased costs, and really the significant benefits can be questioned. So you take out 2 nodules which has the highest scores or which is in the largest in diameters. But clinically, I would advise you to pick up the nodules which have the highest scores. So we ask the radiologist or you do it by yourself under ultrasound guidance, and you send it to a cytologist, which you think that he or she is experienced with pointing out every single clinical detail. So it's not only sending the samples, it's sending the samples together with clinical information. This is what the what the cytologist will need for a more effective decision making, because this has an impact on the clinical decision making of the patient, whether to go for surgery, whether to go for a follow-up or a repeat FNAB, or for molecular testing, if it's available in your country, and if it's, of course, affordable, and if the price is okay for the patient to pay. So what is the Bethesda classification giving, which has been updated last year? It's again a spectrum from 1 to 6. 1 is non-diagnostic, 2 is benign, 3 is atypia of undetermined significance, 4 is follicular neoplasm, 5 is suspicious, and 6 is malignant. So every single one has a risk of malignancy as it's presented here. But even it's reported to be benign, it still has a risk of malignancy. That doesn't mean, of course, that this patient should go for surgery. As you see here for the adult, if it's a benign cytology, which has a risk of malignancy of 4%, we do not go for surgery per se. It does mean that this patient should be on close clinical and ultrasound follow-up, which may be differ from protocol to protocol, but is generally from 6 or to every single 12 months. What do we do with these Bethesda 1 nodules, which are non-diagnostic? Because 50% comes out with this result. It should not be more. It should be, around the 10-15%. Otherwise, they should really question themselves. So Bethesda 1 means non-diagnostic. To reach diagnosis, the samples should contain cells of sufficient quality and quantity, which means at least 10 clearly visualized follicular cells in a minimum of 6 cell groups. How should we approach these patients? For nodules with an initial Bethesda 1 biopsy result that are resected, actually, they have a cancer risk more than expected, which is around the 13% in adults. But here, again, we should not take the message out of this that we should resect the Bethesda 1 biopsies. We should go for a repeat FNAB under ultrasound guidance again. And years ago, we did wait for a repeat FNAB, but we now know that there is no reason to wait for it. So you can do it right after receiving the results of when you receive a Bethesda 1. So you do a repeat FNAB, and then if you get the same result, if you think that this is a suspicious nodule, you can go for a surgical intervention, and that's what we are doing here in Turkey as well in general. What about approach to the Bethesda 2 nodules? Approximately 70% of the FNABs, so most of them, they result in the Bethesda 2, which are the benign ones. So the risk of malignancy, as I presented, is low in these, and it's around 4%. And the classification has changed. So don't be surprised if you don't read a colloid nodule, a hyperplastic nodule, adenomatous nodule. Just when you see follicular nodular disease, this is the changing terminology, which has changed 2 years ago with the new WHO classification. Here you see again the benign cytology is represented. So what we do is generally we follow up these patients clinically and with the ultrasound. But if we have highly suspicious ultrasound features, you may go for a repeat ultrasound and a repeat FNAB. But should we hurry, according to a lot of reports, we may even expand the time for a repeat ultrasound and FNAB, which can last for 12 months. But this depends again from clinician to clinician. But for nodules which are Bethesda 2 and which has low to intermediate suspicious ultrasound features, a repeat ultrasound can be carried out after 12 to 24 months. When do we do surgery in these cases? I would advise to discuss the alternatives if we are sure that the FNAB is Bethesda 2. So that means ultrasound should convince me. Secondly, I should have 2 FNAB reports, which reports Bethesda 2. And I should be convinced that the patient has difficulty in breathing, swallowing, there's a compression, but not voice changes. So if there's a voice change, I definitely, of course, this can be related to pressure of the nodule, but we should definitely exclude the presence of the thyroid cancer. Cosmetic reasons also are there. So we're in between. That's what I did today as well in the morning with the first case. Alternatively, what Andrea Casaril has presented minutes ago, that the presence of ablation therapy is there today, but we have to be very careful, again, in the selection criteria of the patients. When do we do not need FNAB for the patients where we are planning surgery? That's actually those patients who have compressive symptoms, who have a low grade thyroid score, thyroids 2, 3, with, for example, the substernal goiter is a very good example here. And another good example is a patient with a low TSH who has a hot nodule. So be very sure that those patients who are punctured, these patients who are punctured with a hot nodule will definitely confuse the cytology. And in general, you will never get a benign result from them, which will lead them to surgery as well. But for these patients, there are different options now other than surgery. So you know that they already may have the possibility of taking the chance to get radioactive iodine, and another possible chance where the success rate is a little bit less than for the benign nodule is the alternative ablative therapy, which we can discuss. What about the extent of surgery? So should we stay? It's never a nodulectomy anymore. Isthmic resection is still there for an isthmic nodule. But when we talk about extent of surgery, should we stay on one side, or should we do it a total thyroidectomy? So this depends actually what we go for. Are we going for diagnostic reasons or therapeutic? As a surgeon, if you ask me, I do not like to do diagnostic operations. It should be more therapeutic. So everything should be solved before the surgery, which is always not possible, of course. The severity of symptoms, presence of nodules in the contralateral lobe, which is actually questionable. If you have a nodule which is pure cystic and 5 millimeter on one side, and if you have a cancer on the other side, which is about 1 centimeter, for example, or sub-centimeter, then normally this patient carrying out a lobectomy in this patient is more than enough from an oncological point of view. So the presence of that cystic nodule doesn't mean that this patient deserves a total thyroidectomy. There's something that should be underlined as well. Functional status of the thyroid is important. The evidence, of course, of malignancy, the comorbidity of the patients, whether the patient has family or radiation history, which has an impact on going more for a total thyroidectomy, the risks of surgery, what happens actually during the surgery. We may go for a stage thyroidectomy if we have a loss of signal during neuromonitoring, for example, and this patient may not go for a completion thyroidectomy after the definitive result of pathology, where in the very beginning we were thinking about total thyroidectomy, for example. And of course, the decision should be made together with the patient. So patient's preference matters as long as you discuss it in a very honest and logical way. This counts also for the Bethesda 2 nodules if we go for surgery. And of course, we have to weigh the recurrence, the risk with the benefit. So take into consideration complications, be very open actually to it, and then decide whether you go for any kind of kind of treatment you go. So in general, what's going on in practice? If there is a bilateral nodular goiter, this is actually the reality of the Turkish patients. The patients generally receive more total thyroidectomy than they receive lobectomy plus hysterectomy daily. So in conclusion, we see nodules very common. Ultrasound is really easy reachable. So that means what we see in our routine daily practice will increase definitely. Why there is an increase of thyroid cancer? Is it because of the endemy of the ultrasound or all these imaging techniques? We still do not know, but we also do know the impact of radiation. So we, of course, have to take that into account. But we have learned lessons from the Koreans that there is actually no role for screening because, discovering those silent sub-centimeter laboratory cancers and thinking about treating them with surgeries that had no impact on the life expectations of the patient. So there is still no role for screening. And the presence of nodule does not always mean surgery. We should definitely decide about the management according to the patient. So that means one thing doesn't suit all. And we have to take into consideration patient's preference as well. And today, which was not there 20 years ago, we should consider alternatives. I think that we should be very honest. And to be honest, we should learn about all the alternatives.
Thank you very much, Ozer.
Yes, Ozer, thank you for this amazing talk. You have summarized quite a wide topic into these few slides in 20 minutes. And thank you very much for that, because it was actually 2 talks in one. But it was a nice overview from a surgeon regarding diagnostics and how it impacts our work and what should we do and how it should be tailored towards patients and situations, right?
Actually, I was not finished. I was just inviting all the people to ESSO 25 Izmir.
So why didn't you say so?
That was a video. So we have live on the 70 people. If you allow me, I just want to show the video. And
Yes,
invite the people to Izmir. Yes. Let's see where it's going to start. Yes.
Oh. We just don't hear it.
Yes, I just want you to take a look at the pre-conference courses when I'm inviting you to Izmir, which for me it's the most beautiful city in the world. But we do invest ourselves to the quality of our pre-conference courses, which is getting better and better. So if you really think that you will have some advantage taking on these courses, and of course, the knowledge of what you can get from the ESCS conference regarding the guidelines which will come out. So 5 guidelines will come out of this meeting as well. So just see it live, discuss it live, and take the profit to attend one of the courses you see here. In May, next May, I welcome you all to Izmir, and thank you so much for listening. Thank you so much.
So we will be there in Izmir for sure. We promise that. As long as we are inviting people to attend important educational events in close future, I would like with a lot of pleasure to invite everyone attending this webinar to ESSO hands-on course in thyroid cancer that is organized in Madrid this year in October from 10th to 11th. There are still spots for registration. It is my great pleasure and honor to be part of the faculty. So as part of people preparing good lectures and amazing practical sessions for you, I invite you to join us. Also soon, from 1st to 4th of October, we will have ESSO Congress, 43rd one, and there will be a lot of topics in endocrine surgery as well. So feel free to register and also to become members of ESSO. There are many benefits for members. Thank you, Ozer, for sharing the link for the registration in the chat, so everyone has the possibility to see what is the program of ESSO in 2025, and I'm sure that Izmir will live up to expectations of all of us. Gilles, there have been some questions arriving regarding Ozer's talk as well. Do you have something?
Yes, I have one question, and it's an important question for all of you. Do you think that thyroid surgeons have to be trained to ultrasound examination, or it's the role of radiologists?
That's a very good question. Just let me regarding the experience that I have. I'm not doing it in every single patient, but I really do devote myself in doing it in the parathyroid when I give the position of the patient in the operating room. I really want to see the lymph nodes where I'm going, even planning in a compartment-based lymph node dissection. I really look for the lymph nodes that I have to dissect out. So we should be familiar with every single radiologic investigation, whether it's the ultrasound, CT, MRI. But on the other hand, since it's, very, how do you say, it's reachable and it's cheap and you can repeat it, I think that every surgeon should have some knowledge of ultrasound. But on the other hand, in my practice, before surgery, it's not me who is doing the ultrasound. I really want to have the thyroid and the neck ultrasound carried out by an experienced radiologist. That's what I really am investing myself in, and I ask my patient to have it in that way.
It's a good point. Yes, because we have to rely a lot on ultrasound examination, and it should be done by expert. But I think personally that some kind of, as Ozer said, knowledge on all the methods that we use for evaluation is very important. And also it can be useful for quick intraoperative or preoperative preparation, maybe for parathyroid adenomas or something like that. Maybe just for you personally to go around the case a little bit more. Otherwise, it should be done by an expert, definitely. Andrea, what is your thought on this?
I think that I use the ultrasound by myself, like Ozer. I want to add that it's important for the surgeon to use the ultrasound if you are planning to do a minimal invasive procedure and or transoral procedure. This is important that the surgeon has the imaging in his mind. But I want to stress once again one thing that is that it doesn't matter who perform the ultrasound before the intervention, but the ultrasound has to be made by experts, so we can avoid wrong request of fine needle aspiration. For example, 5 millimeters nodules that are suspicious, that can give an overestimated diagnosis. So it's very important to stress that a thyroid ultrasound has to be performed by expert operator in thyroid diseases.
Ozer mentioned something that I think it's really important to stress out today about the physical examination, that it is somehow getting behind all these modern modalities. But how important do you find physical examination of the patient when you face it, him, her first time? Ozer?
Very important.
You're smiling.
This has an impact on clinical decision making as well, because as a surgeon, you learn how to feel when performing surgeries. That's what I'm trying to say. So you're the one who is lucky. You open and you feel it when you extract the tissue. You see the nodule, you feel the nodule, and you know what comes out of it. That means after 1 week, when you have the report, it reports something. So if you think it's a cancer and it's reporting a cancer, then you learn how it feels. That's what I'm trying to say. That's why physical examination is important. So that's why I do physical examination in every single patient, because you may find a nodule, which is described to be a benign one. Then you ask for a second opinion and more experienced radiologist, or there you can discover a second one which is not there in the report of the radiologist. So and this is also true for the lymph nodes as well.
Absolutely, yes, I agree with that. Andrea?
Absolutely agree with Ozer. It's very, very important, the physical examination, and to have the also for the lymph nodes. I perfectly agree, because sometimes feeling the consistency on the mobility of the lymph nodes in the carotid sheaths is very, very important to distinguish what is maybe metastatic nodes or not. So I perfectly agree with Ozer.
And I think it can just push forward the diagnostics, as Ozer said. We can repeat some method and make further analysis based on our physical examination. Yes. Gilles?
I think it's very interesting to practice the examination in surgical position and different position of the head, and it helps you to imagine it, how you can practice the surgery, and if it will be easy or not to practice it specifically for goiters and in the thoracic goiters. So you know that time is passing.
Yes, it is. We
But
could
it was
talk
very
like
interesting.
this all evening. But I think that our participants had an opportunity to hear excellent talks, and I think that the discussion was quite structured and informative. I would ask Andrea and Ozer maybe to make final comments of their talks, or send some final messages to our participants, if you prefer. Andrea?
Before? Okay. The main point is, I think it seems so simple, but work together. The teamwork is what is important in decision making, especially for ablation, because it's important that the endocrinologist, the radiologist, and the surgeon works together. This is mandatory, in my opinion. Then everything come after, but we have to emphasize the importance of the teamwork, especially for these new technologies. But this is my final comment.
And actually, my last words is we try to be, very. We try to serve the best quality in the operating room when we manage the patient surgically. So we should also invest ourselves as much as we do in a preoperative workup, as much as we do in our surgical room. So that means we have to invest ourselves also in the quality of the preoperative workup. It's not taking the patient in the operating room only. That means the quality of the reporting, the quality of your reporting or managing of the patient as well, and taking into the consideration whether there are alternatives, surgically and non-surgically.
Yes, patient-tailored approach and multidisciplinary team decision. Two important messages for tonight. Gilles, do you want to add something before I close up the webinar?
Yes, just a little thing. I completely agree with the idea of multidisciplinary team. And we have the chance to have radiologists in the operating room sometime, and it can be very helpful for decision making.
I agree. Personally, I'm very satisfied with how this webinar went through. We hope that the contents of today's webinar also met all your expectations. I'm talking now to people who are participating online. Thank you once again for attending in the name of European Society of Surgical Oncology, who provided this webinar for free. We hope that you will stay with us on our educational journey because, as I said at the beginning, we have created a special series of webinars that are completely free for people to join and to hear all the updated information on thyroid nodules and thyroid cancer treatment and all the complications. So let me remind you once again about the ESSO Congress that will happen in Antwerp from October 1st, and feel free to join us.
And thank you a lot, Nada, for the work you did. Beautiful program.
Thank you, Gilles.
Thank you.
Good night, everyone.